What should we expect from oral semaglutide in a patient with type 2 diabetes who is already at high cardiovascular or kidney risk? The SOUL trial was designed to answer that question. It tested whether oral semaglutide could reduce major cardiovascular events when added to standard care. This is a useful trial for clinicians because the endpoint was not simply HbA1c, body weight, or a laboratory marker. The question was whether patients experience fewer cardiovascular events. SOUL enrolled 9,650 adults aged 50 years or older with type 2 diabetes and established atherosclerotic cardiovascular disease, chronic kidney disease, or both. This was a high risk population. It was not an all comers diabetes trial, and that distinction matters when we translate the result to an individual patient. Let us state the PICO clearly. Population: adults with type 2 diabetes and established atherosclerotic cardiovascular disease, chronic kidney disease, or both. Intervention: oral semaglutide titrated to a maximum dose of 14 milligrams once daily. Comparator: placebo with both groups continuing standard care. Outcome: the first occurrence of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. Together, these events made up the primary MACE outcome. The fifth part is the design and duration, an event-driven, randomized, double-blind, placebo-controlled outcomes trial with follow-up of approximately 4 years. The primary outcome occurred in 12.0% of participants assigned to oral semaglutide, compared with 13.8% assigned to placebo. The hazard ratio was 0.86, with a 95% confidence interval from 0.77 to 0.96. The p-value was 0.006. So, in this high-risk population, oral semaglutide was associated with about a 14% lower relative hazard of the primary cardiovascular outcome. The absolute difference was 1.8 percentage points. That absolute figure is important because the benefit a patient experiences depends on their baseline risk. The most defensible interpretation is that oral semaglutide adds cardiovascular outcomes evidence for patients who resemble the SOUL trial population. This is clinically relevant when an oral GLP-1 receptor agonist is preferred, when an injectable option is not acceptable, or when the treatment discussion needs to include proven cardiovascular outcomes alongside glucose lowering. The result should not be reduced to a medication slogan. It is an outcomes result in a defined population using a defined dose against a defined comparator. First, SOUL does not prove the same absolute benefit for a younger person with short duration diabetes and no established cardiovascular or kidney disease. Second, the primary endpoint was a composite of cardiovascular death, myocardial infarction, and stroke. Composite outcomes are useful, but they must be interpreted through their individual components and the overall clinical context. Third, the pre-specified 5-point kidney outcome was not significantly different between groups. Cardiovascular benefit from this trial should not be presented as proof of a separate kidney outcome benefit. For an appropriate high-risk patient, I would discuss 5 practical questions. Does the patient resemble the trial population? What is the patient's baseline cardiovascular risk? Is oral semaglutide acceptable and feasible? Can the patient tolerate dose escalation and gastrointestinal adverse effects? And how does this choice fit with therapies that have established indications for heart failure or kidney protection? The SOUL result informs that conversation. It does not replace shared decision making, local guidance, product information, or attention to cost and adherence. The strengths include the large sample, randomized double-blind design, event-driven follow-up, and patient-important primary endpoint. The limitations are equally important. The participants were selected for high cardiovascular or kidney risk. The study was industry funded. The tested dose was titrated to a maximum of 14 milligrams daily. The primary outcome was composite, and the trial did not establish a significant benefit on the 5-point kidney outcome. Statistical significance is not the same as a uniform benefit for every patient. Absolute benefit is shaped by baseline risk. The SOUL trial supports oral semaglutide as a cardiovascular outcomes option for adults with type 2 diabetes and established atherosclerotic cardiovascular disease, chronic kidney disease, or both. The primary outcome occurred in 12.0% with oral semaglutide versus 13.8% with placebo, with a hazard ratio of 0.86. The clinician-facing conclusion is precise. Oral semaglutide reduced major cardiovascular events in the high-risk population studied. The results should be applied according to baseline risk, tolerability, access, and the patient's wider cardiometabolic treatment plan. For the complete PICO summary and full reference, visit Hormone Insight. The source citation is provided in the description for review.